This is an MS Views Now program. We started this in, I think, March or April of 2020, just after COVID began. Okay, this is to provide updates to the MS community about COVID. And then we were doing it just that way first. And then we added in also, other topics like what we will be doing tonight. And I will address that in a minute. For those that are online and have not yet the honor of knowing me, yes, I will say honor or privilege or whatnot. But yes, my name is Stuart Schlossman. I am the president and founder of MS Views and News. I'm also a multiple sclerosis patient. I do what I do because I want to educate all of you. And next we have our supporters, our sponsors of tonight's program. As you can see, they are Bristol-Myers Squibb, Genentech, and Biogen. And of course, we give a virtual thank you to our supporters. Next, I want to tell you about Dr. Krieger. So Dr. Krieger, as you can see, he is a very well-learned person and very excellent teacher of information for the multiple sclerosis community. He's an MS specialist at Mount Sinai Hospital in New York City. He's contributed the Leaky Pool model to the MS world. He's going to be speaking about that tonight. So Dr. Krieger is going to be speaking about things that a lot of you will know nothing about, all right? And I expect that you'll have questions, all right? First, though, the doctor is going to speak for 35 to 40 minutes, okay? And then we will get to the Q&A. So, Dr. Krieger, I would love for you to take this away.
All right. Thank you so much, and I really appreciate the invitation to be here. Well, how did you say it at the beginning? It is an honor and a privilege for me to be here with you and to be able to speak to the crew that you've put together. So I really appreciate that. And, to be honest, Stuart, you have been a long time advocate of patient education in MS, and you have, in that capacity, I think, advocated for spreading some of the messages that I've tried to get out there about how I understand MS and the MS patient journey through this concept called the topographical model of MS, which has been kind of christened the leaky pool model. For that, I got to credit Brett Stetka, who wrote a piece in Scientific American about it that gave it that title, and also my friend Aaron Boster, who has alluded to it that way in many programs, including many of your programs, and I think helped to get people aware of this work. So,
all right. Well, thank you for that. I'm gonna sign off while you talk. People don't want to look at me; they want to watch you, and they want to only hear you, and not pay attention to the shadow of my glasses or whatnot. Okay. But thank you for all those kind words, and I will be back in a little while.
Well, great. Thanks again for having me. So I'm going to talk a little bit about the patient journey in multiple sclerosis, the way I've come to think about it as an MS specialist and neurologist, through the lens of this idea called the topographical model. My goal is for some of these ideas to resonate with you, maybe for you to start to see the MS journey or the MS disease course in perhaps a different way. My goal very explicitly in this is to try to help empower the MS community to understand what the neurologist is thinking about and looking at and looking for, and a way for the MS neurologist to really better understand what's actually happening to the people that we're taking care of. So that's part one. And then part two is going to be kind of a quick primer update on COVID and MS, in particular with an emphasis on new data about COVID vaccines and MS. So we'll get to that at the end. So, okay, next slide. These are my disclosures. So I do work as a consultant with some of the companies that you may have heard of in the MS world. What I don't do are any promotional talks. I never promote a product. I don't stand up there and tell you what product to choose. But I've worked with these companies in developing education materials and sometimes doing some talks that are not about a product, but rather about MS itself, like tonight's talk. Okay, next slide. So let's start thinking about the MS journey and what MS progression looks like, or what the outcomes in MS looks like through a very familiar set of graphs. Probably anybody who's in the MS world or loves anyone in the MS world has seen graphs like this before, of relapsing remitting MS, of secondary progressive MS, of primary progressive MS. And if you Google multiple sclerosis, a graph like this still is one of the first things that comes up. If you look at the Wikipedia page for MS or the National MS Society's education site on MS, versions of this are everywhere. And I think maybe we can do better in thinking about how to consider the MS journey and how we might kind of depict that over time. One thing I will say is there are things missing from these graphs. No two people with MS are the same. And thinking that we can just place everybody with MS on a line that's all going in one direction, I don't think is true anymore. The one thing that these various graphs of disability and time all have in common is that whether it's primary progressive or secondary progressive or relapsing remitting, in these graphs, disability always goes up. And I think 25 years ago, when this was first kind of created, maybe that was true. But I think now, in 2021, someone entering the world of MS now, asking, what's going to happen to me in 5 years or 10 years or 20 years or 50 years, doesn't necessarily need to think that disability is inevitable. I think we can do better. I think we can do better both in how we treat the disease and how we talk about what people can expect, and also how we show it. And that's what I'm going to show you. Next slide. So those graphs kind of, well, they have problems. As I said, those categories are not people. People ask me every day, what kind of MS do I have? Is it relapsing remitting? Is it secondary progressive? And I try to say that these categories are useful for describing populations of people. They're useful in clinical trials. They're very hard to apply to an individual person and mean something. So I'm trying to get us away from these categories because the distinction between relapsing MS and progressive MS, frankly, is not always obvious. Sometimes people with MS feel changes that the neurologist can't see. Sometimes the neurologist sees things on the MRI scan the patient can't feel. It's really impossible to determine the moment that someone changes from having relapsing remitting MS to secondary progressive MS. There is no moment when that happens. Furthermore, not all relapses are the same, and progression is not inevitable, as we said. So I think we can show it in a different way. Next slide. So one of the principal ideas in neurology is that where some piece of damage is in the nervous system defines the symptoms that it causes. And we call this localization. And in my way of putting it, I call it disease topography. The idea that there's a map. So you can picture a topographical map as a map of peaks and valleys and hills and mountains. And in multiple sclerosis, those hills, those mountains are the lesions. And where those lesions are ends up being very, very important. So MS lesions are typically in the spinal cord or the optic nerve. There are lesions that are in the deep part of the brain called the brain stem or the cerebellum, which controls balance. And then there are many lesions in the hemispheres of the brain, which we see very clearly on MRI scans shown here, but very often those spots don't cause symptoms. So I've taken this notion that where the lesions are matters, and I've tried to create a map of the way MS occurs in the nervous system. What all of us have in our nervous system is the ability to compensate for damage, the ability to work around problems in the nervous system, to overcome signs and symptoms of a disease, and keep it under the surface. And that's what I try to show here with the concept of brain reserve. And we all have brain reserve, but different parts of our nervous system have different amounts of reserve. And so when we look at the next slide, you'll see how this plays out in a map of the central nervous system. Imagine that map of where lesions could be at the bottom of this pool of reserve. Reserve keeps that damage under the surface, submerged, so that many people who have MS can keep the disease really quiet, not obvious, not crossing the threshold. It gets to the idea that we've long talked about, that people with MS can look so good, but feel not good, because there's many things that not everybody on the outside can see. So if we look at the next advance here, we're going to put a little caption on the top, and that's going to explain that the central nervous system is this pool of reserve. It has a shallow end, like the spinal cord, and a deep end, like the hemispheres of the brain, different amounts of reserve. The spinal cord, it's a very simple structure. It's about the size of your thumb. And if there's a lesion or damage in that shallow end of reserve, like a lesion in the spinal cord, it typically causes symptoms. Lesions in the hemispheres of the brain are often very well compensated. They hide below the threshold, and this is the fundamental concept of the topographical model. Next slide. Now, when we look at our patients, we look at people clinically, that is to say, we take their history, we think about their symptoms, we examine them neurologically. You've all been through this, where the neurologist is looking at the eyes and the eye movements and the face and strength and coordination and tapping reflexes and checking sensation. All of that is to look and see what signs and symptoms we can detect. And under the surface is what we see on the MRI scan, where all of the lesions that someone has ever accumulated show themselves. Lesions in MS are scars, and scars are forever. However, the amount of reserve that someone has is a much more fluid, much more dynamic thing. Anyone with MS knows, I think, that there can be good days and bad days, and a bad MS day is not the same as a bad day for someone without MS. All the underlying symptoms show themselves again. People know when their reserves are low and their symptoms are more apparent. And that concept, that reserve can go up and down. We are trying with our medicines to prevent new lesions. And one thing we encourage our patients to do is do what they can to fill the tank of reserve. And we're going to talk about that a little bit more. I think helps to modify the course of the disease. Next slide. Now here's what happens over time. Now you see it playing, and what you're seeing here is lesions form and recover, but the lesions stay. And as time passes, that tank of reserve drains. This is the most important kind of image in this whole talk, because what I just showed you there was 20 years depicted in about 20 seconds. And actually, you know what? Let's watch it one more time. Let me go back one and then forward again so we can see it again. Reserve drains as we age, the brain shrinks, and our ability to compensate goes away. And as that threshold goes down, more and more of the underlying MS disease becomes revealed. That's how I think of what progression is. It's something very gradual, but it reveals a particular patient's pattern of symptoms related to where their lesions are, what their disease topography is, that map for that person. Some people with MS have many lesions in the spinal cord and the brain, and those lesions may be the things that drive disability over time. Other people with MS may manage not to have progressive disability over time, and some of that is because they have more reserve. Some of that is because they have fewer lesions. Our goal is to try to bring both of those things to all of our patients. Now, I said at the very beginning, it can be really hard to know when relapsing remitting MS ends and secondary progressive MS begins. It's part of why I try to get away from those terms when I talk to my patients. So what I showed you here was this depiction of, let's say, 20 years, and it all goes by very quickly. I'm going to show it one more time, but this next time you're going to see those categories show up across the top. Let me have you advance one more time. Let me have you advance one more time. I think you went backwards. One more time forwards. Now as this plays, you see the categories appearing: clinically isolated syndrome, relapsing remitting MS, and then later, when reserve declines, secondary progressive MS. And you can see it's really hard to know when in time that actually occurred, because there's really a spectrum here. So one thing that I tell my patients is I care about whether they're having relapses, whether they're having new lesions. I also care whether their symptoms are gradually changing, and we have to look carefully for that. And across the spectrum of MS, from the mildest to the most severe, I feel like there's always something that we can do if we're looking carefully enough for it. Let's go to the next slide. In fact, we can use this way of looking at MS to depict a very broad range of the disease, from very, very mild MS, what sometimes is called benign MS, but That's kind of a hot topic, whether any MS can ever be benign. That's sort of the goal, but whether we can always achieve it is harder. Versus highly active MS disease, where there's lots of new disease activity or new lesions forming, or more gradual progressive MS. So let's look at a couple of those. Let's look at the next advance. When you look at it this way, this is the one we just saw. Someone who has relapsing remitting MS, but as time passes, reserve seems to decline. Even if the MRI doesn't change, new disability gradually shows itself. Let's look at one more. If we look at this one, in primary progressive MS, I believe primary progressive MS is just a form of MS. It's not fundamentally different. I think that people who have primary progressive MS can also develop lesions. They can also have disease activity, but what drives the clinical course, the journey, is really the loss of reserve that allows damage from lesions to show itself clinically. Trouble walking, trouble with bladder, trouble with coordination, that sort of thing. And then let's look at one more. In this last example, and actually you could advance it one more time, this is the idea of mild MS. And if we focus on that, this is in a sense our treatment goal, which is to keep the disease submerged, keep it underwater, keep the tank of reserve as full as possible, and try to keep the disease topography, where those lesions are and how many there are, as flat and as minimal as it can be. So in this example shown on the screen now, this person may have had MS for 20 years. We look at an MRI scan, we see it. But above the surface, there's nothing. And if we can achieve that or seek to achieve that, I think that's a more optimistic goal than those old graphs where disability always rises. Here we see what it looks like when disability doesn't cross the surface. Next slide. Now, what do we do with this? So this is my kind of educational concept, my educational platform. It is, in fact, an app that runs only on the iPad. It doesn't run on an iPhone. It only runs on an iPad. So you have to, if you're going to look for it, you have to search the Apple App Store with an iPad. If you look from a phone, nothing shows up. It's called MS Topography, only because I couldn't get the words topographical model of MS underneath the app icon. It was too long. So MS Topography. And it basically shows you what I've shown you here, but you can page through it. You can look at these different aspects of disease course. You can have it annotated with information. It's got references in it. So I think it's maybe a useful teaching tool for somebody who wants to go a little deeper into this concept. Next slide. What I try to use it for is explaining complicated things like this. Above the threshold, we see only a little bit. Below the threshold is what the MRI shows us, and we see a whole lot more. So what we see when we examine our patients, a little bit of a tip of the iceberg. And part of MS care means getting MRI scans routinely to look below the surface and see if there's anything we could be missing that could be important for treatment decisions. So that's one thing that this model kind of shows us, the distinction between what's clinically apparent and what we can see on the scan. Let's go to the next slide, please. Now, sometimes people can get much worse, but they aren't actually having a relapse. We call this a pseudo-relapse. And what you just saw there happen really quickly, and maybe we'll look at it one more time, is if you go back once and forward again, now watch what happens to the water. The water can suddenly drain, reserve can be depleted. What causes that? Things like fever, a urinary tract infection, being overheated, being profoundly dehydrated. All these things transiently drain away our reserve. And for someone with MS, it allows all the underlying disease to become more apparent. So someone who feels worse in all the usual ways, all the old MS symptoms are back again or worse than ever, but it's the same symptoms they always have. What I worry about is that they're having a pseudo-relapse, a draining of their reserve due to heat, infection, metabolic problem, and not necessarily a new MS relapse. Why does that matter? A pseudo-relapse means we have to find the infection or treat the fever or bring the temperature down. doesn't mean that someone has a new lesion and needs steroids. So in my practice, I try to use steroids only when someone truly has a new relapse, because giving someone steroids when what they really have is a urinary tract infection can be very, very harmful. So this model tries to show sometimes the reserves can be high and sometimes low. Next slide. Perhaps the hardest questions that we get asked are, what kind of MS do I have? And I kind of already talked about how this model blurs those distinctions, a mixture of relapses and progression, and honestly trying our best to prevent both. And the second question, why do I feel worse if my MRI hasn't changed? And sometimes it's a hard question to answer. And I think the answer is people can feel worse if their reserves are declining, if in a sense the brain is aging faster than it should, which can happen in MS. We don't always see that on an MRI scan. It doesn't always mean there's a new lesion. There may not be. So the lesions under the surface may be fixed. They may not change. The amount of reserve may decline. And we need, as a field, I think, to get better at measuring reserve and boosting reserve and building brain health. But I think that's the reason that sometimes people feel worse even if the MRI doesn't show it, because the MRI is showing the lesions. It's not necessarily showing us the reserve, the water in this model. Next slide. Now, I keep talking about boosting reserve, and I wish that I had the kind of data for boosting reserve that we have for our disease-modifying therapies, but I think the idea that what we can do to maximize brain health helps to keep the tank full, I think that's a powerful concept. So we send our patients for physical therapy and occupational therapy. Why? Those things help the brain to make new pathways, to compensate for the damage done, to make workarounds, to be more efficient. And all those things, I think, help to keep the disease submerged and build reserve. We talk to our patients about diet, having a healthy diet, and we can talk a little bit about what kinds of diets are out there and how we think about it. There is no one diet for MS, but there are certainly a lot of ways that diet can damage reserve. High salt diets, high fat diets, diets full of processed food, these things poison our brains, all of us. And trying to minimize those things helps to optimize brain health, and things that help brain health fill the tank. We talk to our patients about quitting smoking. A recent study at ECTRIMS looked at tens of thousands of people and found quitting smoking actually helps the brain to heal itself and minimizes risks of progression. It's not surprising. Smoking is toxic to all of our organs. Of course, it's toxic to the brain. Removing that toxicity helps the brain to heal and helps to fill the tank. We can talk more about these things, but it's one thing as a doctor to say, oh, you should stop smoking. And I don't know that that always reflects how hard that is. But I think if you can visualize the goal, keep the tank full, allow the brain to compensate well, keep the disease under the surface, I intend for that to be motivating. These positive health-related behaviors can be visualized this way. Next slide. If you have found this compelling, thought-provoking, interesting, even if you think it's all wrong, I encourage you to look at it in more detail. So I'm going to tell you one or two things about what's out there. I originally published this as a paper in a journal called Neurology, Neuroimmunology, Neuroinflammation. We abbreviate that N2 in our field because it's a long name. That article is what's called open access. You don't need to have a subscription to see it. You don't need to be in an academic library online. You can just Google it and you will see it. So if you look up my name, Krieger, topographical model, you will see that link. It'll be one of the first ones, and you can look at the PDF. I encourage you just to look at the PDF link, which goes right to the publication. All the graphics are in there, all the pictures. It's easy to read. And it's detailed. I mean, that's the scientific paper on it, which if you want to go deep, talks about the rationale for this thing. If you'd like to have the more interactive version and you happen to have an iPad lying around, the MS Topography app for the iPad is much the same. a little bit less of the academic language and a little bit more interactive if you'd like to look at it in more detail. So these are two ways that you can see it. They're both obviously free and available for the MS community. Next slide. So that first part is my take on the MS journey through this particular concept. And obviously, we can talk a little bit more about your questions and how your understanding of progression or relapses or the treatment goals can kind of be seen through the topographical model. But I wanted to put that out there as sort of the concept, and then I'll see what kind of questions you have. The second part of the talk, which is much shorter, is sort of a brief update on MS and COVID. I feel like one can't do a talk in 2020 or 2021, probably also 2022, without talking about COVID-19 and its impact on the MS community. So we're going to talk a little bit about MS and COVID, medications, and vaccines. Next slide. This is the National MS Society's COVID website. And frankly, I think it is the best single source of information for the MS community, which is out there. This was created with a whole bunch of MS specialists around the country. It's frequently updated, and it has information on MS and COVID, resources to utilize, updates on the disease, and I think it's a useful starting point. Some of the main lessons we've learned. MS itself doesn't increase someone's risks from COVID. That's good news. However, our most vulnerable patients are the most vulnerable to COVID. And what do I mean? Our patients with MS who are more physically disabled, who are older, who live in a care environment or long-term care facilities. Those are the folks that have had the roughest time with COVID-19. People with MS and other comorbidities like obesity and diabetes and asthma have had a rougher time with COVID. Our medications have largely not increased COVID risk, although there's going to be a detail about that in a moment. But we don't think of our medicines as necessarily profoundly increasing COVID risks. But we definitely want our patients in the MS community who are on immune therapies that may suppress aspects of their immune system to maintain vigilance and be cautious and be smart about trying to avoid COVID risks where they can be avoided. And everyone has to find a balance of living one's life and not putting oneself at risk. And everyone's going to draw that line in different places. And you have to do what's right for you. But I will say, trying to protect our community of people with MS, particularly those on immune therapies, during this pandemic has been a real challenge, and I think this National MS Society website is a very, very good resource to help navigate it. Next slide. The second resource that the National MS Society has put out is their advice about COVID vaccines and multiple sclerosis. This remains a controversial topic in many ways, but some principles I think we can say very confidently. Number one, the vaccines for COVID-19 that are approved in the United States are safe for people with MS. The National MS Society strongly advocates for people with MS to get vaccinated to protect them from the disease. There is no evidence that these vaccines really increase the risks of MS relapse or other autoimmune problems for the MS community. No vaccine is 100% effective or safe, but the benefit of being protected from COVID outweighs the risks from the vaccine to our patients by probably 1,000 to 1. And so it is a personal decision, but I think the data is very, very positive that these vaccines work. They work in the MS community, and we're several billion injections into it now. So one thing I have said to my patients, particularly those who were concerned, especially early on, that the vaccines were too new and came out too quickly. Now, in fall of 2021, I can confidently say to you, you will never take a medicine for the rest of your life that's been given to as many people as these vaccines have. Billions and billions of people. So for any of you who are on an MS medicine, MS medicines are typically tested in 2,000 or 3,000 people before they're approved. When they come out and they're used for years and they're very successful, maybe a couple of 100,000 people have been on any one of our individual MS therapies. So these vaccines have been given to not just hundreds of thousands or hundreds of millions, but billions of people. The experience and body of evidence with them dwarf what we've done in MS profoundly. And if you trust, your provider, your healthcare provider who's helping to treat your MS with medicines, we have thousands of times more experience now with these vaccines. So they were new, but not new anymore. So this page from the National MS Society, I think, is very useful guidance for vaccines, for people with MS, and the guidance around that. And nowadays, the hot topic is really around booster vaccines. So now that we are, roughly 10 months into the vaccine era for COVID, the recommendations are turning towards boosters for people who got their first round of vaccines 6 months later. And that is particularly true for people who are on immunotherapies that could decrease the efficacy of the vaccines, like our B-cell depleters, including rituximab, Ocrevus, Kesimpta, and our S1P modulators, which are pills like Gilenya, Mayzent, and Zeposia. It's also probably true for some of our infusion medicines like Lemtrada or alemtuzumab. So folks who are on these more sort of immune powerful medicines are strongly encouraged by the National MS Society to get a booster if you haven't already. And both the Pfizer and Moderna boosters at this time are available in the US for those folks. Let's look at the next slide. So this slide underscores the point that I made earlier that MS itself didn't increase COVID severity, and our medicines in general didn't increase COVID severity. But this was a slide from our ECTRIMS Congress, which just happened in October of 2021. And what this particular slide showed is that our B-cell depleting medicines like rituximab and Ocrevus could modestly increase COVID risks. Not enormously, but modestly. And so as you're thinking about, what's worth doing, what risks are worth taking if someone's on a B-cell depleting medicine like these, I think maybe they can be twice as cautious because the risks from COVID are perhaps twice as high. And so it's not hugely different, but it might modify our actions a little bit to try to keep these folks as safe as possible. So that's one new piece of data about our B-cell depleting medicines and COVID probably increases the risks mildly and worth taking into consideration. One more slide. I think this is my last slide. So how about the efficacy of our vaccines across our treatments? And this is much harder to study because the vaccines are incredibly effective at preventing COVID. I mean, really remarkably effective, frankly, better than we'd hoped for. So about a year ago, in November or early December of 2020, when we first started seeing the data for the COVID vaccines, it really blew all of our minds as to how well they actually worked. Now, a year later, we're looking at how well do they seem to work in different MS therapies. And what this slide shows is that the amount of antibodies that someone produces after they get a vaccine is one way of indicating how well that vaccine worked. And I know the slide's a little small, but across the board, you see these high numbers of antibodies for both the Pfizer and the Moderna vaccines. Moderna, as it turns out, caused more antibodies. The Moderna vaccine seems to have been the most potent in terms of the antibody response. But when you get to, on the right side of the slide, the people who are on B-cell depleting medicines again, like rituximab and Ocrevus, or our S1P modulators, like fingolimod, Gilenya, siponimod, Mayzent, or ozanimod, Zeposia, those antibody numbers come down a bit. It's not terribly surprising because the way those medicines work is they sort of take away circulating white blood cells called lymphocytes, which are needed to mount the antibody response. But this is something we're looking at closely. It's important that people who are on these medicines who've been vaccinated understand that just the amount of antibodies doesn't indicate how well protected someone is from COVID. There are other things in the immune system that are not related to antibodies that also provide immunity, like T cells and other cell lines in the immune system that we can't measure, but they're there, helping to fight COVID for people who've been vaccinated. So I do think if someone's on a medicine that decreases the antibody response after vaccination, I could understand that they're nervous. I respect that. And I think that, they can maintain precautions to try to really keep COVID away from them and away from their families and out of their homes. But we don't think that the antibodies tell the whole story. So this is evolving. We're going to know more a year from now about this than we know now. But at this point, the advice is certainly get vaccinated, irrespective of what MS medicine someone's on. That's the general advice. We can look at antibodies, but I don't want low antibody numbers to freak people out too much, because I don't think they tell the whole story of the vaccine response. Boosters are going to be useful to make sure that everybody remains protected, particularly as we go back into the winter this year. And you can certainly seek out the National MS Society's webpage for this guidance as it evolves. So last slide. That is my final one. I'm bringing it back to my topographical model here, which again is sort of my career contribution. And I will stop here at 38 minutes past the hour and turn it back to Stuart for our question and answers. So thank you.
Bravo, bravo. I mean, if I were at a play right now, I'd be giving a standing ovation. That was fantastically delivered. Fantastically, if that's a word I can say right now. I am going to say it over and over again because you have a way with words that so many people need. This is truly a very understandable discussion, and I do thank you for that. And it clearly was not over the top. All right, so we're going to reserve the reserve. We're going to reserve the reserve for later. And first, we're going to discuss some of these COVID questions. I'm going to mix it up back and forth with disease progression as well, because we just have a tremendous amount of questions that came in prior to, during, and even from a lot from the local community. So firstly, what can you tell us about what's happening in Europe with COVID? So a lot of people are hearing that there's this surge that's beginning to take shape again. And number one, is it because people are beginning to shelter again, or is there a new variant?
Yeah, that's a great question. Probably a little bit of both. I think this virus has continued to mutate in part because vaccination was not adopted 100%. To be honest, if the population globally had really gotten on board and gotten vaccinated thoroughly, and of course, if there had been a more equitable distribution of these vaccines across the world right from the beginning, we probably could have stomped this thing out. A virus can't mutate if it doesn't have a host. So if everyone were immune to it, it would die out and then it wouldn't continue to go. So to be honest, the reason we have new mutations, the reason why the pandemic didn't end, is because not everybody who could get vaccinated did, and not everybody in the world got access to vaccines. And that remains a problem, both of those things. So I do think that there will be changes to the virus itself because it finds a foothold and then it changes. And I think we are probably seeing that in Europe. But there is a seasonal quality to this infection because, as you said, people socialize and shelter indoors in the winter, and people indoors, eating indoors, gathering indoors is where the vast majority of this virus gets spread. It doesn't really spread in outdoor events because there's just so much more air and so much more air movement. Whereas in a closed space, which is where most of us are in the colder climate in the winter, that virus has an opportunity to spread. So I am concerned that that's going to happen in the US as well. Obviously, some parts of the US have high caseloads while others are lower. So where all of you are as you're watching really is going to make all the difference in terms of what the local risks are. But I think the other aspect of it is vaccines, for those who got them, are wearing off. And so not everybody's gotten a booster yet. So as the vaccines from early 2021 wear off, now there are more people who are vulnerable, who are not yet boosted, for the virus to have a foothold and infect more people and mutate again. So I think both of those things are happening, and I think it's important for the MS community to be cognizant of that.
So the concept of herd immunity, what happened with that? I mean, we heard about it so much so prior to vaccines. We heard about it when vaccines first started to come out. Now you don't hear anything about it really anymore. And can you tell us what the reason is for that?
That's a good question. I mean, I think, herd immunity is great when there's one type of infection. If there's only one thing and enough people are immune to it, either because they've been exposed and recovered or because they've been vaccinated, then again, it snuffs it out. It snuffs out the flame because there's not enough folks that are vulnerable. When something has a lot of different strains and it keeps evolving, again, because it finds footholds in communities that are still vulnerable to it, where vaccine numbers have been low, it's hard to have a herd immunity against that because it's a many-headed beast. I will point out that the main difference between the version of the virus that was really prevalent this year, what was called Delta, one of the main differences between that and the version of it that was the original version from late 2019 and spring of 2020 in the US is the version from early 2020, the original COVID-19. If one person got it, statistically, they could be expected to give it to 2 people. Delta, if one person got it, they could statistically be expected to give it to 9 people. It was much more contagious. And it's awfully hard to develop herd immunity against something that every one person with it is going to spread to 9 other people. So I still think the goal is to protect as many people as possible, but you're right, we're not really talking about herd immunity anymore. We're talking about protecting every individual person as best as we can.
Okay. I don't know if I should stay on the same line of that we're on right now, stay with COVID, and then we'll get to the other ones. I want to keep it continuing, all right? So going back to what you were saying about third world countries, with the prevalence of the vaccine not even reaching most people in those third world countries, now when these people get on a plane and go traveling somewhere into the modern world, what are they bringing with them? And, how effective is their not being vaccinated or them carrying something going to affect those that are in the modern world that have been vaccinated?
Well, I would say this. I think it's a tragedy that we haven't yet gotten enough vaccine supply to parts of the world where people are very vulnerable and haven't yet been treated. And so, the wealthiest countries have had by far the greatest manufacture and distribution of these vaccines. That is starting to change, but not fast enough. But to be honest, I don't think the problem is folks from underserved countries flying into the United States and bringing disease with them. We've got plenty of people in the United States who had that disease right here and spread it to their friends and their communities and their congregations. And honestly, for a long time, it was the US that was the worst hotspot exporting it to the rest of the world.
That's right.
So, I think we should worry less about what folks from other places are going to bring to us and more what we can do at home to keep everybody safe, and maybe what the US could do at large to try to help protect the rest of the world.
Okay, thank you for that. Now, you were saying about, there's a flu season. Should we now expect that there's going to be a surge each year and call it a COVID season?
Yeah, I mean, it's an interesting concept. So, in prior years, so flu season, seasonal influenza is endemic in the southern hemisphere in their winter, and then comes to the northern hemisphere in our winter. And it's very predictable. And year to year, the flu season would start at the same time, it would peak at around the same time, it would come down. Last year, when much of the world was engaging in social distancing, mask wearing, hand hygiene, stuff that just we hadn't done globally the way we did last year to try to minimize COVID spread. Last year was the lowest flu season in modern history. Flu season, at least in the northern hemisphere, basically didn't happen. And it's because we were trying to mitigate the spread of one virus that spreads through aerosol and through exhaled air from one person to another. And by protecting us against that, we also really minimize the spread of influenza. It was the lowest influenza year in history, in recorded history. I think that if we keep our precautions up to some extent this year and also get flu shots, we could try to keep the influenza season from happening, once again. I do think that COVID will be worse in the winter in general, as you said earlier, because of everyone clustering inside, but it's not really a seasonal virus. If you think about it, there have been COVID spikes in New York in the winter, in Florida in the summer. There have been COVID spikes in Europe in their winter and in their summer. So it doesn't really, it's not temperature dependent the way influenza is. It's not sort of seasonal in that way, but I do think that there will be ups and downs. And if we can appropriately minimize those risks for the MS community and for people at large, we could try to get it under control so that we don't have to stop living our lives to minimize risks from COVID any more than we stop living our lives in flu season. We live our lives in flu season, but we are smart about it and get flu shots. And I think if we're smart about it and get COVID shots, we could try to keep those risks to a minimum and try to also live our lives.
Okay, thank you for that. Now, a person named Bruce he wrote a question. I'm not quite sure what he wrote, so let me read it, and if you can't figure it out, then I'll try to figure it out with you. Since long COVID, is the immune system overactive and MS is overactive? Can MS patients have a bigger or lower chance for the long COVID?
I can understand that question. I can try to answer it. So long COVID is this description of folks who've had a COVID infection, recovered, but been left with residual symptoms that are often brain fog, fatigue, lassitude, pain, headaches. All of that should sound very familiar to people with multiple sclerosis who very often have fatigue and brain fog and pain and discomfort and low energy. So there is something very similar about the symptoms of long COVID and some of the sort of quote unquote invisible symptoms of multiple sclerosis. I don't know, however, that we really understand what is driving long COVID for many people. I don't think we know that it's an overactive immune system. I mean, I'll go one step further. We don't know that it's an overactive immune system that's doing that. We don't know whether it was a direct effect of the virus on the nervous system. There's a lot that remains not understood about that. Mount Sinai in New York has had a long COVID care center, sort of a center of excellence. They do their best, but I think it remains incompletely understood. That said, I do think that if someone with MS has brain fog and pain and fatigue and they get COVID, I do think they're at high risk for having more brain fog and fatigue. So all the more reason to try to keep the MS community as protected from COVID as possible. It's really the last thing someone with MS needs. But I think the actual mechanisms of those two things, we still need to work them out.
Okay, thank you. Another person wrote in, what can you tell us about the third booster for MS patients? How safe is it?
Great. So yeah, here I'll refer again to the National MS Society's MS and COVID website, which has a whole section on the vaccines and in particular the boosters. Short answer is the boosters are basically the same vaccines that we all had the opportunity to get and got earlier this year. The Moderna version of the booster is a lower dose of it because they basically found that the dose that they came up with in the first place was a little more than people needed. So the booster is a half dose. The Pfizer booster is basically the same vaccine as folks who got the Pfizer vaccine in the first place got. So the safety is the same for people with MS. It is outstanding, and we should get it. So there's one example, and I've said this to lots of people I take care of. There's one example where I'm not telling my patients to do anything that I haven't done myself in this case, and that I didn't get my family to do as soon as they qualified. Yes, we should give the boosters, the 6-month boosters to folks with MS and to everybody else that we love and care about.
Great, thank you. So can you tell us why certain people had shot number one from, let's say it's Pfizer or Moderna. They had shot number one, they had shot number two, and they did not have a reaction. Came time for a booster, and all of a sudden they felt flu-like, or they felt extreme fatigue for a week, and or other things that came up. Is there a reason for that?
Yeah, it's a good question. The amount of side effects to the vaccines, either the first dose, the second dose, or the booster, really varies enormously between people. It probably varies a little bit with age. So the older someone is, the less likely they are to have really significant flu-like symptoms after the shot. And that's because as we get older, the immune system is a little bit quieter. It's a little bit less overactive. And so the amount of side effects, at least amongst all the folks I know and the patients I've taken care of, during this time, I feel like the folks who are in their 80s and 70s have had less side effects than the folks in their 60s and 50s, who had less side effects than the folks in their 40s and 30s. And the folks in their 30s and 20s really were under the weather for a little while. Now that varies a great deal, but I don't make too much of how much side effect there was to the original versus the booster. It doesn't really mean whether it worked then or works now. And I would say for first shot or a booster, a little Tylenol or a little, NSAID like Aleve or Motrin or that sort of thing, and some hydration should take care of those side effects for the vast majority of people.
Great, thank you. What can you tell us about mixing the boosters, like between Pfizer and Moderna?
So the FDA approved and has allowed, and the CDC has allowed this mix and match approach for a couple of reasons. One is I think they wanted to maximize the accessibility of the boosters. And the logic is it's far better to get a mixed booster, so not the same as one got before, than it is to be told, well, we don't have the thing you had before, so you can't get one. So I think some of it was a practical decision to say better to get someone a booster than no booster. The second reason was folks who got the Johnson & Johnson vaccine did not have as much of a benefit. The J&J vaccine didn't work quite as well, and it didn't last quite as long, and so they wanted to make sure that those people had the opportunity to get Pfizer or Moderna as their booster. Those are the main reasons. I think if someone got Moderna or Pfizer before, they can get Moderna or Pfizer afterwards, and there's not really a compelling reason to mix and match between those two. So for instance, I got Pfizer back in January of 2021, and I got Pfizer again in September. For the booster, there wasn't really a need in my mind to switch it up.
Okay, I'm going to ask you one more question on COVID. And
Cool.
then if we have time at the very end, because we do have a lot of disease and MS-related questions to ask, but at the very end, if we have any time, I want to know, and I think the audience will want to know about how an MS neurologist was requisitioned to work in the COVID ward in Manhattan during the tremendous surge that New York City had, and what you had to live with at that time. So I'm hoping we have time at the very end to hear from you about this, and I'm hoping everybody sticks around for this as well. In the meantime, let's get into these other questions. The last question on COVID was about what's the latest information you have on COVID and the Ocrevus therapy, and will taking a booster lessen the gap on the suppression caused?
Yeah, it's a good question. So I'll allude to the slides at the end of the COVID section for those who might not have seen that part about B-cell depletion and the COVID vaccines. We do think that the B-cell depletion decreases the amount of antibody. We definitely want folks who are on a B-cell depleter to get boosted to maximize their immune response. It is very plausible that we won't see high levels of antibody, but that doesn't mean other cells in the immune system, like T cells, aren't taking up the charge, learning what they need from the vaccine, and helping to protect people from COVID. So more on that on the MS Society's website, which outlines some nice guidance about B-cell depleting drugs and the vaccine booster.
Great, thank you for that. All right, now let's get into this leaky pool theory. Let's get into the disease progression. let me let everybody know that as far as the leaky pool is concerned, you can find that on the MS Views and News website as well. All right. And you just, if you can't find it, send me an email and I'll give you the information. Okay. All right. We have a lot of questions to go through. Let's talk about reserve first, and the questions that have to do with the reserve, the functional drop in reserve as it applies to people under extreme fatigue or stress.
Yeah, great question. So I talked about things that can boost reserve, like healthy diet, exercise, physical therapy, etc. But you're absolutely right. Profound stress can lower one's reserve. Fatigue and sleep deprivation can lower one's reserve. The brain needs sleep in order to be resilient. We can't have overwhelming amounts of stress or our brains fail to function properly. Sorry if I'm being drowned out by sirens. I live right near the Mount Sinai Hospital, so that's the sound of New York right there for you. And so this is part of why I think we focus on sleep management and treatment of fatigue, because I think it's a very literal example of the brain needing that sort of resource and respite in order to have its full ability to function. You know, MS fatigue is very complicated. It's probably partly related to the lesions and partly related to the inflammation and partly related to the metabolism in the brain. But the one thing that everybody with MS should really try to do is optimize their sleep, treat insomnia, treat reasons why someone's waking up multiple times at night. That's really essential because with sleep deprivation, no amount of treatment for fatigue is going to be all that helpful. The brain needs sleep. So I think that's a perfect example. And I think it adds up over years and decades. Years and decades of sleep deprivation is harmful to reserve. We're studying that. My colleague Jim Samowski and Alana Katzand and others at Mount Sinai are looking at sleep and fatigue as modifiable lifestyle factors to try to optimize brain health. I think we're only going to see more on that.
So I should be a study patient of yours in that capacity, because unfortunately my brain is constantly telling me at 2, 3, and 4 o'clock in the morning what I need to be doing the next day, what meetings I have coming up, how I have to prepare for upcoming events. And I'm only finding that I'm sleeping an hour and a half, I wake up, 2 hours, I wake up, I'm up for 2 hours. I'm starting to have a lot of optic neuritis again. I'm starting to have problems with remembering what 1 + 1 is, and how to mix my coffee in the morning. I mean, it can be that bad. The travel this weekend added to, the feeling overwhelmed and going through too many spoons. And so I think it's very important for people to understand that and what it is doing. And I did understand it, and I plan on doing something about it. But people really do need to account for what's going on in their lives and how that might be creating worsening of their MS.
100%. It is really hard to turn the brain off, especially we're all doing so much and multitasking so much. The COVID pandemic has not helped matters in that regard, with this mixing of our work lives and our home lives in ways that many people didn't have to do before. It's hard to shut it off, but that is something to work on. So I encourage you to work on that so that you get a little more sleep in your night.
I'm trying. Today my eyes are feeling heavy, so I might actually sleep for 3 hours tonight.
Good. Perfect.
Okay. All right. Next question. Continuing on the reserve. Does the reserve in every brain decrease over time?
Good question. To some extent, yes, because there is some natural aging which happens, and none of our brains can do when we're 90 what they could when we're 20. But in MS, it can happen faster. So I kind of describe what drives progression for many folks with MS is this accelerated aging of the brain, which is part of the disease. And we know that. But the absolute cellular drivers, what's happening on a cellular basis to cause that, that's still an area of deep research in our field. Not everybody loses reserve at the same rate. And I think personally that whether the tank drains quickly or the tank drains slowly, kind of at the normal aging rate, makes all the difference in the world in terms of whether someone with MS has progression or not. that's an area of research I'm working on with a couple of projects at Mount Sinai with Jim Samowski and folks at a imaging company called Icometrics, where we're looking at how can we measure brain volume and cortex volume and see if that helps to explain reserve and the loss of reserve. So more coming on that. But I don't think that loss of brain reserve has to happen very quickly in everyone. We need to find more ways of slowing it down.
Okay, thank you for that. And I do hope that when you have more to discuss with the brain volume, that you let us know so we could do a topic based on that alone.
Great.
Okay, next, once symptoms are evident, can rebuilding neural pathways increase the reserve?
I think so. And again, this kind of comes from my clinical experience, and it comes from looking so carefully at my patients. But, I think I said before, why does physical therapy and occupational therapy help? They help because they allow people to build new pathways, grow new workarounds for the lesions that are there, and have the brain function more efficiently. And I think of that as a boosting of reserve. And, I think this is also where just physical activity in general, social connectedness in general, becomes so important. The MS Society has talked about this for years, building connections. And I think building connections in our lives, building connections within our brains and nervous systems are ways of rebuilding and fostering reserve.
Great, thank you. So Cindy online is asking, when your MS neurologist only has 15 to 20 minutes with you twice per year, how in the world can they begin to know what is above the tank? As you said, this is not what is not seen on the MRI.
Yeah. Well, listen, that is sort of a appropriate indictment of modern American healthcare, which is, we have less and less time to try to do more and more things. I would say, listen, we're all limited in how much time we can spend with our patients. I don't get much more than 20 minutes, but you try to have a really high yield 20 minutes. And I will say I try to see my patients a little more frequently than once a year or even twice a year. I used to see folks every 3 months. That's much harder to do now. But you can come in with the topics and the symptoms that are important to you, have your agenda ready so that you can lead with it to guide your neurologist or your healthcare provider to focus on the things that are important to you. The doctor comes in with their agenda also. We have the things that are on our minds. What does the MRI look like? When was the last time we monitored blood tests on your medicines? Looking at the neuro exam, whatever the things are, risk mitigation for drugs, for our therapeutic drugs. So we've got an agenda. You need to make sure your agenda is heard, is on the table. And then I've been encouraging neurologists to try to look harder. If we do a more thorough exam, we'll see things that are more subtle. That's actually also work that Jim Samowski has pioneered at Mount Sinai, doing more challenging physical and cognitive tasks. So we have a wellness program now that tries to be much more comprehensive about cognitive dysfunction and fatigue, and diet, and trying to manage all those other things, in part because we can't do it all in 20 minutes, 25 minutes in an office visit. So we try to build that in as part of comprehensive care. I think this is why folks with MS should at least occasionally be seen at MS centers by folks who do bring nurse practitioners and social workers and dietitians and physical therapists to the table, because we can't do everything. And neurologists can't do everything, can't see everything, but we should be looking. And you should come to that table, come to that encounter ready to talk about the things that are important to you to help us to see them.
Okay, thank you. Karen is asking if it's okay to be taking medications after being 65.
That's a good question. And, one thing I can't do is give individual medical advice over this, because not every 65-year-old is the same. But one thing we don't have is we don't have data for the efficacy of our MS medicines for folks over 65. They weren't studied in our clinical trials. So we have to collect data from real world. We have to look at large registries of people who are treated with these medicines in the real world who are 50, 55, 60, 65 and up in order to better understand that. There's a study being done now led by the folks at the University of Colorado, Denver, looking at what happens if we stop MS medicines for people over 55 who've been stable for years. Does it matter? So we don't have the answer to that yet. That study is done, and we're going to see the results of it, I expect, this year. It's going to help to answer that question. But even when it does, we're going to have to personalize that. If someone is 65, they've had MS for 40 years, and they haven't had a relapse since 1988, maybe that person doesn't need an MS therapy. The risk of relapse is very low. On the other hand, I have people who are 65 who have new relapses, new lesions, not a fluctuation, not getting overheated and feeling lousy, but true new attacks with new lesions on MRI scan. That person, 65, but their immune system is acting like they're 35. That person needs to be treated differently. So it's not a one-size-fits-all answer, but I acknowledge that there's uncertainty in our field around it because our clinical trials can't really answer the question. So I await the results of the University of Colorado Denver study. That's going to be a real step forward to help answer it.
Thank you. And what do you do for a person who is 66, 67, 68, 70, who first gets diagnosed with multiple sclerosis? Do they get put onto a therapy?
That's a great question. That's a related question in the sense that, yes, MS is most common onset in people's 20s, 30s, early 40s, but big range. People who are pediatric age who get diagnosed with MS and folks in their 60s who get diagnosed with MS too. One thing that's hard is when diagnosing someone in their mid-60s with MS, figuring out, did they really just develop this now? Or have they actually had MS for 20 years hiding below the threshold and now we're seeing it? So the topographical model kind of helps to visualize that. Maybe it's been there for many years and it's only becoming apparent as that person ages and their reserve declines. That's a somewhat different scenario than someone who has a brand new diagnosis of MS, optic neuritis, enhancing lesions at age 65. It's rare, but it happens.
Okay, thank you. All right, next, Deborah is asking, is it necessary for MRI scans to be done with contrast for all patients? At one time, doctors were suggesting that contrast was not always essential.
Yeah, that's also a good question. So if you'd asked me that 10 years ago, I would have said, yeah, we pretty much use contrast for most MRIs most of the time. But our practice has changed a little bit in that respect. The FDA put out a guidance probably 5 years ago now that some people retain MRI contrast called gadolinium in their system. It's not known to be harmful, but it changed our thinking a little bit. Instead of saying, well, someone who's 40 years old, probably going to have, 30 MRIs and, the rest of their 60 years on this planet, maybe we shouldn't be giving them contrast every single time. And so now I try to use contrast only when needed. And routine MRI scans, if we're just comparing this year's scan to a year ago or 2 years ago, in the absence of new symptoms, you don't need contrast for that. You can compare this year to the old one and see if there are any new lesions. Contrast only shows us if a lesion is brand new, currently inflamed this month. And in the absence of new symptoms, I don't think we generally need that. So certain circumstances where I use contrast, a change on exam, so new symptoms, new findings, a change of treatment where we really want to see, is there any disease activity happening right now? If someone hasn't had a scan for a long time, I might want to get contrast because if I do see new lesions, helpful to know, are they new right now or were they new years ago and we're only finally seeing them now? So different circumstances call for contrast, but I don't use it in everyone all the time because mostly it's become a little bit less necessary.
Okay, thank you. All right, next, going back to the reserve person, Rebecca is asking, can the death of a person, reclassified, can the death of a friend cause the reserves to deplete?
Well, listen, I think
Yes.
I think that grief hurts us in a lot of ways, and I think that grief can be incredibly depleting. I think grief can interrupt our sleep and depress our mood, understandably. I think the loss of a connection to a loved one, every loss of connection can cause the brain to withdraw a little bit. I don't think of grief as necessarily toxic to the brain. I think it's normal. I think it's a part of normal life. But some people, for some people, I think grief can be all-consuming. It can stop someone from moving and living and taking care of themselves and sleeping and all sorts of other things that damage the brain and drain reserve. So I think we need to be generous to ourselves in times of loss, let ourselves have it, not worry that it is necessarily itself so harmful. But I also think that we need to make sure that we're having that person who has suffered a loss remain connected, remain moving, remain taking care of themselves, keeping their lives as full and their reserves as full as possible.
Great, thank you. And do the reduction of reserves also lead to brain atrophy?
So I tend to think that brain atrophy is a way of looking at the loss of reserve. So I don't know that I would say reserve leads to brain atrophy. You could maybe make the argument that brain atrophy is the loss of reserve. That's the area of research that I'm working on with, as I mentioned, the icometrics folks doing brain volume testing and trying to figure out if we can really use brain volume to measure reserve. I think of them as being very related, but it's not a one-to-one thing. I can't look at a brain MRI and say, well, this is how much reserve someone has. It doesn't correlate so perfectly. Brain MRIs are a picture. They're not necessarily telling us the function of someone's brain. And I think reserve is more about their function, functional reserve. So you can kind of think of brain atrophy tells us something about the structure. We need better assessments to figure out the degree of someone's function, brain function and functional reserve. But I do think they're related. And I think as we get better at doing that sort of imaging, we'll be able to tease that out better than we can now.
Okay, thank you. I have about 9 questions remaining before we get to your big thing, okay? All right, so we didn't know how long this was going to last. Now we know, okay? All right.
All right. I'll be quicker in my responses. I've been long-winded. Let's do a lightning round. I'll do a lightning round of 9 questions.
We can do that. Is Provigil, about Provigil, can it help with fatigue? Yes or no?
Sometimes. Studies are kind of equivocal about it, actually. Some studies have shown that it does help MS fatigue. Other studies have shown that it doesn't. I think unless it's contraindicated for a particular person, if there's, unless there's reasons to avoid it, it can be worth a try for fatigue. But I think the most important treatment for fatigue is restoring someone's sleep. Things like Provigil come much later.
Sure. And is it beneficial if you have high anxiety?
Is what beneficial?
Provigil. Yeah.
I mean, Provigil is a stimulant. And so I think one has to be actually careful about using stimulants in people with high anxiety, because high anxiety is sort of an overstimulated state to begin with. It's fight or flight. It's all adrenaline. So I think one has to be careful with stimulants and anxiety. So I don't think stimulants help with anxiety. I think you have to use them cautiously.
Okay, cool. All right. Before I go on with these other questions, there were a few people that agreed with me when I was screaming out bravo when you got done with your talk. And I just want to let you know that there were several that clicked on yes, I agree, or yes, wrote bravo as well. I want to let people know before I get to the rest of these questions that tomorrow night we're doing another virtual event. It's on the cognitive aspects of multiple sclerosis. It's with psychologist Rick Harris, who has done a tremendous amount of talks with us over the years. He's very well versed with people with multiple sclerosis, and he has many MS patients. He will be speaking about this tomorrow night. We will have this online also at 7 p.m. Eastern time. So whoever's not already registered for that, we have like 1,200 people registered. But for whoever's not, just know that that you can get onto our website and get registered for it. All right, now I'm going to finish out with these questions. Let's see how fast you could do them. After 30 years, identified and clearly in secondary progressive, what is the most common cause of death?
Well, we tend to say that MS is not a fatal disease. However, profound disability can definitely shorten life. And so in someone who is significantly physically disabled from anything, really, from spinal cord injury, from stroke, from MS, the biggest risks to life are problems from mobility, bed sores, urinary tract infections, and sepsis. And for folks who have difficulty swallowing and managing their secretions in their saliva, the risks of aspiration and pneumonia. That's not unique to MS. That's true for all kind of physically disabling conditions, but I think that's true in MS as well. So I think one has to be vigilant for those threats to well-being, particularly for folks who've really had a long and progressive course.
Thank you. All right, in different age groups, because I'm combining questions here, different age groups that are, say, 45 plus, 55 plus, 65 plus, is there anything that can benefit the lessening of symptoms different than DMTs, exercise, and diet?
Well, I would say, DMTs are designed for prevention. Exercise and diet are designed for health optimization and brain wellness. And then individual symptoms need to be addressed on their own terms. So someone who has fatigue, one can address that symptom. Someone who has pain, we can address that symptom. Someone who has gait dysfunction, we can address that symptom through physical therapy, occupational therapy, medicines like dalfampridine. So one thing that I tell everybody that I teach about treating MS, so physicians, medical students, nurses, what I talk about is find the good that you can do for the person that's in front of you. You can always find some good to do for that person if you look carefully enough. And I think symptom management is one of those things. It's right there. And it's an opportunity for the clinician to affect some good for that person. And for all of you, it's an opportunity to say, hey, the thing that's a threat to my well-being right now, that's affecting my quality of life is this. What can you do about it? And you can align your agenda with that of your healthcare provider.
Okay, thank you. Next, the person writes, I have SPMS, non-active. Then why am I losing function? Shouldn't I be stable at this point? What is causing the continued progression?
Yeah, so that is the real theme of the topographical model part of this talk, which is that non-active secondary progressive MS means someone is not developing new lesions. They're not developing new relapses, but they may be progressing because the reserve is declining. That's my hypothesis. They may be progressing because the brain is aging in an accelerated way, and it's unmasking, it's revealing areas of damage that are not being compensated for. It is the hardest form of MS to try to treat. I think it's the greatest unmet need we have. And I think I know there are now clinical trials going on for people with non-active secondary progressive MS and non-active primary progressive MS, looking at new treatment strategies to try to slow that down. So I would say to anyone out there who's in that situation, yes, we can't do everything we want for it yet, but we will be able to, and I would encourage you to try to look for clinical trials of that in your area and see if it's something that you might want to participate in.
Okay, great. Thank you for that. Next, we have, so about the trials, are there any age limits?
Yeah, every trial has an age limit, and different trials set that age limit differently based on what they're looking at. So yes, it's true. And you'd have to look and see which trial you're looking at and what you might qualify for, and if you meet the age threshold. It's tough because companies are not looking at folks who are 65 and 70 and 75 in their trials, but often there are trials that go to age 60, so you do have to look for it.
Okay, thank you. 5 remaining questions, because 4 are tough because I wrote them. Okay, and then
I don't want to take your questions. I want to take everyone else's questions.
I've given we've already gone through all theirs except one more that just came in online, and I did ask you a couple of mine already as well, and from our own team. All right, but these last 4 I'm gonna hit you up with in a moment. Let's answer Stephanie's question first. What is worse, a relapse or continued progression?
Well, it's a value question. I think that's different for different people. I mean, I think relapses are inherently a little bit more amenable to treatment. The definition of relapse is it gets better. Steroids are often used to make that happen, more quickly, perhaps more effectively. Progression is, in principle, less reversible. I do think it can get better. That's what filling the tank of reserve is really all about. So I guess if I had to choose, I would say, we can do more for relapses now, but I want your neurologist to be aware of both if you're having both, and see what can be done for both ends of that spectrum.
Okay, thank you. All right, here we go. You ready? If primary progressive MS is thought to be something slightly different than multiple sclerosis, first off, can you explain that? And secondly, can you tell us what causes the continued worsening in a patient with PPMS?
I think PPMS is MS. I don't think they're fundamentally different. And I think that the worsening that happens there is that loss of reserve over time, that atrophy of the brain and spinal cord, that loss of the ability to compensate. And that's why I'm optimistic that these new trials and medicines that are being studied for non-active progressive MS may finally allow us to do more for that than we've been able to do before.
Okay, then therefore, can you tell us the difference between PPMS and SPMS and what causes the continued disease progression in and with SPMS?
All right,
I told you I'm going to hit you up with a few. So
look, I'm gonna give you a provocative answer. You ready? In my heart of hearts, I don't think there's any difference. I think
between
MS
SPMS and PPMS.
I don't think there's any difference. I think the only difference is whether someone happened to have an event that crossed the clinical threshold when they were younger. They happened to have something that we knew as a relapse. Then later we call it secondary progressive MS. If they didn't have that, we call it primary. I've never seen an MRI difference, a blood marker difference, a physical exam difference, a prognosis difference between secondary and primary progressive MS. I think they're fundamentally the same thing.
That being said, then
that's
why?
My personal view. That's
I
a personal.
know. I got it. It's your personal view. But that being said, then, do you treat your patients with PPMS and SPMS the same? Do you give them the same type of medicinal therapies?
Yeah, in principle, I do. I mean, I think in terms of treatment strategy, you have to meet the MS where it is. And so I will use a broad spectrum of medicines in all of these phenotypes and all these different kind of categories. I try to personalize that decision, but I don't make too much of the category. I don't place too much emphasis on that because at the end of the day, as I said, I don't think that really defines differences between people.
Okay, thank you for that. By the way, I don't know who Deborah's writing to, but thank you for your humanistic and caring presentation. Yes, I'm sure she's talking about you. Okay.
I mean, she might have been talking about you. You're pretty humanistic.
She just rewrote both. She just rewrote both for both of us. Okay. Thank you, Deborah. All right. Next one is you first.
No, you.
Okay. Can you explain the disease progression in relapse remitting multiple sclerosis? And for those, there are a few people that are actually asking me tonight how to explain relapse remitting multiple sclerosis.
Well, I would say if you look back at this topographical model example, and again, folks can Google it and look at it on the original paper. They can look at the iPad app, MS Topography. They can look at the talks you've had on MS News about it. The depiction there is when new lesions form, they cross the threshold, they're acute, they cause a new symptom, and as that lesion recovers over days or weeks, that symptom fades back below the clinical threshold, and that's a relapse, a new event, a new lesion, a new symptom. These are inflammatory events. This is why they respond to steroids. This is why our disease-modifying therapies can really do a great job of preventing them because it prevents new inflammatory lesions from occurring. But people with relapsing remitting MS can also get worse gradually. And that gradual worsening is what we call secondary progressive MS. This is why I think the categories sometimes get us into a circle, because I think everybody with MS can have signs of relapse and can have signs of progression and it's on us to look carefully for them. But I don't get into the individual categories of people because I think it's misleading, honestly. And I think we can get closer to the truth if we listen more carefully to our individual patients and focus less on what category we think they fit into.
Thank you. What is the range of progression, disease progression in relapse remitting versus SPMS or PPMS?
Yeah, so I don't think these are different things. So what I would say is if you look at the topographical model, you can stop thinking of MS in those terms at all. It becomes all about, is someone having disease activity and can we prevent it? Is someone having signs of progression and can we prevent that? Full stop.
Gotcha.
And I think looking for, and I actually say this in the original paper, looking for differences between these categories biologically, never going to find anything. Because those categories were made to put a name on what our patients tell us. Right? There's no biological difference between these things. So I think the goal should be prevent relapses, prevent lesions, prevent progression. All three in everyone with this disease.
Okay, thank you. Katrina just wrote in, if steroids don't, you handled that perfectly. I'm glad that you were able to answer it like you did, because I've thought similarly, but I can't get people to listen to me. So I would love to sit down and meet with you one day and we'll talk about this further, okay?
I'd love that. Listen, you've got 1,100 people registered for your things. You've got 11,000 people following you on Twitter. I think people are listening to you.
I think so. Thank you very much. And another person, well, a few people are writing in that we're both very humanistic. Well, I'm going to tell you humanistic. As soon as we get done with these questions, we're going to get into the last one that I wanted to reserve, going back to the COVID thing with Dr. Krieger and what he did. And that is human power. All right. And I'm going to get to that in a few moments. Okay. I feel like I'm doing a talk show here. All right. So Katrina's asking again, if steroids don't speed up the recovery of a relapse, is it the right choice during an exacerbation then?
Well, steroids are intended to speed up the recovery of a relapse. And I should say, from a terminology perspective, we use the term relapse and exacerbation basically synonymously. New lesion, new focal area of inflammation somewhere in the brain or spinal cord or optic nerve causing new symptoms. Steroids are intended to help that recover more quickly. I think if someone's having a relapse and steroids don't seem to be helping at all, then the neurologist needs to really think a little bit about whether this is a relapse or could it be something else. People with MS are allowed to have other medical problems, so we need to make sure that we're not missing something and crediting everything that someone is going through to their MS. Generally speaking, relapses recover, and generally speaking, steroids make it happen faster.
Okay, thank you. All right. So
Good.
Other people are writing, they can't wait for you to come back on again. But yeah, you're right about that. All right, now, finally, here we go. You ready, everybody? We're going to hear Superman Krieger here, okay? I would like you to please tell us about how you as an MS neurologist got selected to be part of the process. How did you get selected to work in the COVID ward? I believe you were at Mount Sinai, and how you made it through that, and what it did to you as a person, and how you felt every day, and getting home and getting rest and so on. How did you keep going?
Well, I'll tell you, first of all, thank you for asking it. And for those of you watching, I'm happy to say a few words about it just to give you a sense of that experience. When COVID struck in New York in spring of 2020, it was very much an all hands on deck approach. And so basically, virtually every able-bodied physician who is not over a certain age limit and who didn't have comorbidities that could make them at even more risk was asked or called upon to try to contribute to the response to COVID in New York. And so I was one of those folks. As a neurologist at Mount Sinai, our chair asked us to step in to work in the COVID units, which were basically taking over the whole hospital at that point. For those of you who are not in New York, Mount Sinai is right next to Central Park. This was right at the time in spring of 2020 that a field hospital was being built in the park to try to help the overflow. Our entire lobby was turned into a field hospital. at one point in April of 2020, in the Mount Sinai hospitals, which are a few hospitals in New York City, we had 2,200 COVID patients in the hospital at one time. So I was by no means the only one in my department, and actually several of the MS specialists in our group at the Mount Sinai MS Center were called in to do this work. So we had a crew of MS specialists who were each assigned to a COVID ward with a team of interns and residents and medical students to take care of these patients. And this was before we really knew much of anything about how to manage COVID. So it was terrifying. I'm not going to lie. It was very much a back to basics experience for me, becoming an internal medicine attending in a new pandemic as someone who's very specialized in MS. I have a few things to tell you. One is hierarchy doesn't matter at all when you're trying to do the right thing for people. And it didn't matter if I was a full professor, an assistant professor, an intern, an anesthesiologist, whatever it was, we were side by side. So in so many things, in academics, in the military, and otherwise, there's such a hierarchy, and didn't matter. And that was actually kind of liberating to just have a very unified mission and purpose to take care of people who are afflicted with something that was brand new. And I actually, I don't think I've ever been really burned out as a doctor, because I love taking care of patients and I love teaching them, but it was very real and kind of raw and very different than what I do all day, which is I see people in my office and we talk about how to keep them well for the next 50 years, right? That's what MS is about. It's about treating people with disease-modifying therapies for which we have so much data to help keep people well for 50 years. And this was totally different. This was take care of people in a hospital, in a pandemic, make quick decisions, get in and out fast, keep them alive, get them through, get them home. Really different. But it brought me back to sort of the first principles of being a doctor, of finding what good I could do in those rooms. And honestly, I was grateful to do it. I wrote about it. If anyone who's watching this is interested, I wrote my first ever narrative piece about what it was like to be a doctor and do this work. It's only a few pages. It's not very long. But if you were to Google the words Krieger, COVID, redeployment, that's what we called it, being redeployed to work in the COVID units. If you look up Krieger COVID redeployment, it's also open access. It's free. You don't have to subscribe. You can see it. It was published in Neurology in fall of 2020. And I talk about this in a little bit more detail. But, you guys heard me talk about COVID risks tonight and vaccines. And I think I maybe was passionate about it or came across that way, because it's true. And when you've had people die in front of you, you get pretty passionate about trying to protect the people that you love and take care of from this thing. So it probably is why I spent as much time talking about vaccines and safety and boosters and all this as I did, because my fundamental, allegiance is to the MS community. And I've tried to bring some of the experience I had taking care of people with COVID to the MS community to try to keep them safe. So thank you for letting me talk about that a little bit here at the end, but it was a very moving experience for me, and it kind of informed what I've been talking about.
And if I had a hat right now, I'd be taking it off and saluting you with this, because you definitely deserve it. You definitely go above and beyond what most people have in this world, and we definitely do thank you for everybody that you did help through this unfortunate time.
I appreciate that. And again, I want to say, I had a whole crew of other neurologists at Mount Sinai that got redeployed to do this, several of us at our MS center, and there was real solidarity in that also. And I think, I think we did a little bit, and now we just got to get the rest of us through what hopefully will be the late part of this COVID world.
That's right. And let's get back to treating patients. Let's find a vaccine for the MS community, okay?
I think we've learned a lot about vaccines from this. That actually may come back to bear fruit for us. I would not put that out of possibility. I think there's work on that right now.
I got it. I understand that. And again, thank you very much for being online with us tonight. and I'm not going to keep you on any longer. I know you want to eat dinner and get back to the family maybe, and get some good sleep, because you got to get good sleep for the morning. Okay. So
All right.
I will speak to you. Be well. Have a great night. Thanks again for everything. Everybody, join us tomorrow night. Thank you. Goodbye.